Good afternoon, everyone. Can you all hear me okay? Okay. Welcome to the 2026 Advances in Child Maltreatment Prevention lecture. Before we begin, I want to go over a few housekeeping notes. For those of us joining in person today and you wish to receive CEs, please make sure you sign out at the back when you leave. You will not be able to receive CE unless you sign out. There will be time for Q&A at the end of the event. If you are joining us in person, there are tabletop mics at your tables. Press the button, it'll turn it on, you can speak into the mic, and please make sure you turn it off when you are done speaking. If you are joining us online and have a question, please put your question in the Q&A box. We will try and get to as many questions as we can. With that, I would like to invite Dean Beth Angel to the podium to welcome you to today's presentation.
Thank you, Madison. Good afternoon, everyone here in the room and everyone online. Happy Social Work Month. It's great to be celebrating with opportunities for community and learning with you this afternoon. As Madison said, I have the privilege of serving as the Dean of the School of Social Work, and I'm very honored to welcome you to the Advances in Child Maltreatment Prevention Lecture, which is an event we hold every year. I'm also very happy to welcome, though I will not introduce her yet, but I'm happy to welcome our distinguished guest presenter, Dr. Brenda Jones-Harden of Columbia University, here to the University of Michigan School of Social Work. Professor Jones-Harden is an exemplary leader in the area of child welfare, and she will be properly introduced a little bit later in the program. But first, I want to tell you a little bit about this lecture series. The Advances in Child Maltreatment Prevention Annual Lecture was created by Professor Todd Herrenkahl, who serves as the Marion Elizabeth Blue Professor of Children and Families here in the school. And this lecture features the work of leading prevention and child welfare scholars engaged in efforts to strengthen and reform child-serving systems. This lecture provides a forum for new and emerging knowledge from the social sciences and the helping professions that can improve the health and well-being of vulnerable children and their families. That's really what it's all about. So I would like to then turn things over to the creator of this series and today's moderator, Todd Herrenkahl. And let me tell you a little bit about Dr. Herrenkahl. Dr. Herrenkahl's primary research interests focus on the areas of child and family well-being, child maltreatment, and the psychosocial and developmental underpinnings of health risk behaviors in youth and adults, substance use, mental health and physical health outcomes of adversity, and resilience. He's also worked to raise awareness of the causes and consequences of violence in children and families, and to promote the use of public health models of primary prevention and trauma-informed care, especially in school settings. So with that, I will pass things along to Professor Herrenkahl, who will lead us through the remainder of the event and introduce our distinguished speaker. Thank you all for being here, and I hope that you enjoy today's lecture, and happy Social Work Month.
Okay, thanks so much, Dean Angel, for that introduction, and welcome everybody. There's some students in my class back here, and I appreciate your being here in person, all of you, and the rest of you as well. It is my pleasure and privilege to introduce our speaker for today. Brenda and I, Dr. Jones-Harden and I, were reminiscing and realizing the last time we had seen each other was about 18 years ago in Seattle, when our kids were in preschool together at one of the local preschools there. And so we've been in touch over the years, but never hadn't been back in person until now. So it's a pleasure, Brenda, to have you here with us today. Let me say a little bit about Brenda, Dr. Jones-Harden, and her work. Dr. Jones-Harden is the Ruth Harris Ottman Professor of Child and Family Welfare at Columbia University School of Social Work. She was previously at the University of Maryland School of Social Work for about 30 plus years, right, is what you were saying. Her research focuses on the developmental and mental health needs of young children who've experienced adversity, including those who have been maltreated. Dr. Jones-Harden has led and collaborated on numerous research projects and is currently one of the principal investigators of an expansive longitudinal study focused on brain development and behavioral outcomes of young children who've experienced adversity. Her work centers prevention and risk mitigation through early childhood programs, including parenting interventions, early care and education, home visiting services, and infant and mental health programs. Brenda has been a consultant, a mentor, and a leader in the field of child and family welfare for many, many years, and her research has been highly influential and highly cited. I am thrilled to welcome Dr. Jones Harden here today to the University of Michigan, and grateful, Brenda, for your willingness to take time out of your schedule to join us today. With that, I will invite Brenda to the podium. And again, thank you all for being here today. We'll have a Q&A period at the end, as Madison said, so please hold your questions until after Brenda finishes.
Hi, everybody. It's so nice to be here. I was also telling Todd that when I was a little girl, I had to come to Detroit every summer on the train to stay with my great grandma. And she was a tough cookie, tough cookie. So my memories of Detroit are, I would say, ambivalent. But I'm glad to be here. My aunt was like, I want to come with you. She was a member of Hartford Memorial Church, and every time she comes back up, she feels so much better. But I told her she couldn't come with me this time. But glad to see you all. And I'm going to talk about little kids. I don't know anything about adolescence. I don't know anything about emerging adults, except Todd and I were talking about our 23-year-olds and how we don't like this developmental period. It's rough. It's rough. But I love little kids and was so excited to learn that I could build a career around little children. Didn't think that was even possible. When I was in social work school many decades ago, I went to NYU. Nobody talked about little children. It wasn't something that we were trained to even think about. Even in our human behavior course, we talked about childhood, not sort of separating out infancy and toddlerhood and early childhood period. So I'm warning you all today, I'm only going to be talking about 0 to 5-year-olds. That's all I know about. That's all I talk about. So let me just start with what convinced me to focus in on this little group of children. And I know you all have probably been paying attention to the amazing advances we've made in terms of brain research in this country. Now, because we can use these non-invasive kinds of things like MRIs and EEGs and things like that, we have learned so much more about the brain. I'm no neuroscientist, but I am a groupie of this research, really am. And through my fellowship with 0 to 3, I got exposed to all these people who were very, very focused, not only on brain development, but also on infant mental health, that I thought, this is what I'm going to do. I'm a prevention person anyway. And what they convinced me, and I hope I'm going to convince you all of the same thing, is that if you're really a prevention person, you want to start at the beginning, because that's when you get most return on your investment. But I'm not saying we shouldn't deal with adolescents and emerging adults. I'm just saying you get higher return on your investment if you start here. So let me just tell you about little babies' brains, just a couple slides about that. First of all, you all have heard about brain plasticity, I'm sure, right? And it doesn't mean that when you're my age, we still don't generate neurons. It just means that they happen much more slowly. You get lots of neuronal development when you first come into the world, even before, right? When you're a fetus, you get all this neuronal development. But importantly, you get all these connections, synaptic, connections that allow the brain to adapt to his or her environment, right? So that's important, that the brain starts with all these neurons, right? And you see it's like 1 million neuronal connections per second. But then what happens is, once the child comes into the world and figures out, oh, I have to adapt to this environment, or I have to adapt to that environment, the brain starts to prune off some of those connections that will not allow them to adapt in their environment. And one of my favorite examples has to do with language, right? You have a child who comes from a language like Swahili, right? And so their parents are speaking Swahili, and then they bring them to the United States, right? And they're exposed to English. So that little child's brains, the connections that help them to understand the syntax and the sounds in Swahili stay, and the connections that help them to understand English, because that baby understands, not cognitively, obviously, but the brain is ready, primed to deal with whatever kind of environmental inputs they have. So that's so important as we think about maltreatment, because if you are brought into an environment where you are loved and nurtured, like Barry Brazelton used to say, somebody who's totally in love with you and gives you that experience, those parts of your brain that allow you to connect about attachment and all these kind of things stay intact. Alternatively, if you're in an environment where you're abused or you're neglected, the parts of your brain that are primed for you to have those connections die off. So, what I want to make sure is that we're giving little kids the prime opportunity to experience the kinds of environmental inputs, because, right, we know early experiences matter. It's not just you come into the world and what you get with your brain is what you get. The environment matters. I want to give them the optimal chance to have the best brain they can get, right? Now, I just want to say to you all right from the beginning, I am not an advocate of taking these kids out and putting them into foster care. That's not what I'm talking about. I'm talking about, and you'll hear this later on, is helping their parents to respond to them in a way that allows that kind of nurturing experience to happen. That's really where I fall. Okay, so I'm just going to show you this picture of the brain. This is a PET scan, right? Which basically looks at things like glucose metabolism. How much energy is your brain using to solve a problem? And what you'll see on that side to your left is the brain of a healthy child. And you see all that extra red and yellow, which means that the brain is metabolizing more, right? Using more glucose to solve whatever problem is in front of them, as opposed to the brain on your right, which is the brain of a neglected child, right? Where you see much less activity in the brain. So, what does that tell us? That the brain is uniquely responsive to what kinds of experiences they have. And when I talk about toxic stress, I'm going to talk to you all about how now we know that maltreatment gets under the skin. Trauma gets under the skin. So when I talk to teachers in childcare programs, I do a lot of work with Head Start and places like that, and they are screaming about these bad kids. I say, why? Why? And when I talk to them about how these children's experiences of trauma have affected them at the level of the cell, at the level of the brain, and that's why they see the behavior, it really helps them to think about it in a different way. Okay, this is another slide. I show this to every class I teach, so I had to show it to you all. This is from the Romanian orphanages study. You all probably know there are lots and lots of studies, lots of Western people who went across to Romania at the end of the reign of the dictator Nicolae Ceausescu. And you might remember what happened in that time. He wanted to raise the economy of Romania by telling people to have more children, right? Because in his mind, having more children meant you would have a larger workforce and you'd be able to raise the economy of this pretty poor country. What he didn't consider, however, was that these were poor people and how are they going to raise these children? So what he said to them was, have them anyway, the state will take care of them. And his answer to having the state take care of them was to build all these institutions. Now, you all know that would never happen in this country. Thankfully, we know back from World War II that institutions are not good for little people. But he built these institutions. So Western people came over in some cases and did randomized controlled trials to get kids out of these institutions. Now, you know, our IRBs would never, ever authorize anything like that, but they were able to do it in Romania. And what they found, and stuff that we knew about, 40 years ago, but they got brain data to back it up now, is that if you compare the children who were adopted out of Romanian orphanages to regular children adopted in Great Britain. This is a Great Britain study, but there lots of Americans have done this study. There's an science, I think it's the Science Journal that has a whole discussion of the Bucharest Early Intervention Project, if any of you are interested in that. But those children, this is looking at cognitive impairment, pretty much the same, what you'd expect in a general population. But if you start to look at the kids who stayed in the institution longer than 6 months, those children had a much higher likelihood of having a cognitive impairment. And then if you look at the ones who stayed in after 24 months, their level of cognitive impairment was around 1/3. So what does this tell us? There's something in child development theory and research called sensitive period. And that is the optimal time in which you would gain a certain skill, right? And so we know that certain kinds of skills, language, early cognition, the sensitive period is in the first 3 years of life. So for the first time, we had data, brain data, that showed us, yes, institutional care prevents children from having certain kinds of experiences that are critical to their development in the first few years of life, right? So what does that tell me as a child welfare person? I don't want these kids moving from place to place when they're under 3 years of age. I don't want them going to an assessment center first and then going to a temporary foster home and then going to another foster home and then going back to their families. That kind of instability in the first few years of life gets in the way of some critical sensitive periods, I would argue, particularly for something like attachment that we want to make sure children experience. Again, am I saying that we should take all these kids out and have them adopted by 6 months? No, but I'm saying we should have them in a permanent home by 6 months. And that when I go talk to child welfare workers, that's what I say. 6 months, that's it. Look at these data. I want them in a permanent home somewhere by 6 months. Now, I always say to them, I understand, I know you can't work miracles, I know it's hard, but have that as a guidepost for yourself. Because we are, as we have said in many cases, those of us in this field, we are re-traumatizing these children by having them removed from their homes and then experience instability. There's some research on NSCAR, National Survey of Child and Adolescent Wellbeing, which is a great study. If you all haven't looked at it, you need to go. You get all the briefs free. Just go on ACF's website. They haven't erased that from the website yet, so you can get those kind of things. But Cecilia Casanueva has done some great studies where she's looked at early instability and finds that children under 2 experience on average 2 placements. Too many. All right. This I'm not going to stay on for a long time. I love this diagram. It's from the CDC. It's helping us to understand the risks and protective factors that relate to child maltreatment. And I just wanted to point out to you all, I'm in the relationship quadrangle. That's where I stay. I really am thinking about how can I use what I've learned about relationship-based approaches to get children those experiences that the brain data tell us we need them to have before they turn 3 years of age. Okay, another conceptual issue. I mentioned to you all toxic stress. What's the definition? Heightened activation of the body stress response system in the absence of protective relationships. Now, that does a couple things for me. One is focusing on protective relationships. It's not just about risk. It's protective. What can we do to buffer children against adversity? And from my vantage point as social work clinicians, we know how to help children get some kind of protective relationships. That we can do. We can't, change this country and make child poverty go away, although we should. It's ridiculous that it occurs in this country, and I'll talk about child poverty in a second. But we can always try and ensure that children have these early protective relationships that really are important, are critical to their development in the early years. And I would argue if we could get them early, we won't see so many kids in child welfare later. And I'll show you the epidemiology on some of those kinds of things. But this is from Jack Shonkoff. I'm a Jack Shonkoff groupie too. He's a pediatrician at Harvard. He started the Center for the Developing Child. His whole focus now in the latter part of his career is to take the brain science to legislators so they can vote for policies that support young children. That's what he's doing. And the Center for the Developing Child has this framework called toxic stress. They're the first to admit it's really not a real thing. They just made it up, and they had a good ad person come and help them come up with it. They're now actually, they got some money, I think, from MacArthur to try and see whether it's really a thing. But what he defines it as is like what happens. You all know, right? The cortisol, you've heard about those studies. Cortisol is our stress hormone. It's like our morning cup of coffee. It goes up and then it declines over the course of the day. That's sort of typical for everybody. But for children who've experienced toxic stress, according to Jack Shonkoff's framework, it's like on all the time, on all the time. So it's like fight, flight, fight, flight. And then we wonder why they are punching each other out in Head Start, right? Because their little stress response system is going on over time. And there's some suggestion that the other alternative, which is when kids turn off, like say, oh, this world is too much. I can't handle it. I'm putting my head down. I'm not dealing with it at all. So you see this blunted response that those children have even worse outcomes, right? The idea is that we want to help children not have these experiences. And there are data now that hyperactivation of the stress hormone starts to get to the brain and it starts to affect brain functioning. So then you understand why you see the behavioral outcomes you do. But obviously, he calls maltreatment one of the primary risk factors for children experiencing toxic stress. One of the main sources of toxic stress. It gets underneath the body. So you see it in terms of that cortisol release that I just talked about, but you also see it in things like immune responses. So, you see higher rates of asthma in poor and traumatized children. Yes, it has to do with the environment. We've learned lots of things about the environment. Yes, Kennedy's right about certain things. The environment can be bad for poor children, but it's also the kinds of traumatic experiences they have that makes them more likely to have these kinds of issues like asthma. Okay, and then we see the child outcomes that I'll talk about just really quickly that has to do with physical, mental health, and all those other kinds of things. All right, let's hit the child welfare system. I'm not going to stay too long on this, but I do think it's important for all of us to be on the same page. You all know we got a three-legged stool in child welfare now: safety, permanency, and well-being. And I will tell you, when I first started my work as a little child welfare social worker in New York City, we only had safety and permanency. And we were just starting with permanency with the Adoption Assistance and Child Welfare Act. Permanency wasn't even something anybody thought about until the time that I was starting. And now we've got this third stool, which is well-being, which really the data show we're not doing so well on, right? The idea was, if we have these children in our custody, right, as foster children, or if we've identified them because of Child Protective Services kind of investigations, we owe them to try and make sure that we're doing something in their favor. And it's looking like we're not doing so well here. I mean, we're trying, but the outcomes that we thought we would see with that aren't good. And again, I'm going to talk to you all about what we know and how, if we had the political will, we'd be able to address this. Because we know what to do, at least for little kids. Again, I don't know anything about adolescents, but for little children, we know what to do to promote their well-being. Okay. I am not going through this big whole thing just to put it up there. It is a complex system. We have developed this hugely complex system to support these children, and it still isn't working. It still isn't working. And I'm sure you all have heard all about the abolitionists who are saying we just need to blow the whole thing up. Just blow it up and start from the beginning, or not have it at all, is really what they're saying. And when I look at this, I understand their point. I am not an abolitionist. I'm just going to tell you right from the beginning that's not who I am. That's not what I believe. I believe we can reform it. But when you look at this, you say we spend all this money to have people at all these different places. We've got all these decision points. And at every decision point, there's an opportunity for us to do better for children, and we end up not doing better for children, particularly minoritized children, which I'm going to also talk about with the racial disproportionality issue. But let's talk about little people in the system. Let's talk about the epidemiology. First of all, when you look at the national rates, little children are much more likely to be victimized than all other age groups. And I'm going to show you a graph in just a second. Okay. Not only are they more likely to be victimized, but this is the part that makes me so sad. They represent the highest group of children who experience child fatalities due to maltreatment. And that makes sense. They're little defenseless creatures. They can't go next door when they're hungry and say, Miss Jones, can you give me a peanut butter sandwich? Right? They're stuck in their cribs or running around the apartment, toddling, right? Or, if they're being abused, it matters more than it matters for an older child, right? So almost half the fatalities are little infants, right? So that's one of the things that makes me most worried, because the abolitionists are yelling about how we don't have how we're doing too much surveilling, right? That's the big point that the abolitionists are making. And it is true. Poor communities are surveilled more than middle class communities. No question about it, right? But I have a hard time sleeping when I'm thinking about babies under the age of 6 months because nobody's surveilling them. And they're the most at risk. They're at heightened risk, right? If you think about, for example, when's the peak of perinatal depression, right? The immediate postpartum period, where those little teeny defenseless babies are home, and we do not have the infrastructure like Great Britain, where, in your community, they're sending out home visitors to you. Everybody gets a home visit. So somebody's laying their eyes on those very young children when they're most vulnerable. We don't have that in this country, although we've moved there with home visiting, which I'll tell you about in just a minute. So more likely to be maltreated, more likely to die from maltreatment. But we got this other problem, substance use, right? And now child welfare is tracking these. All these little children who are coming to the child welfare system, most of them have some kind of substance use issue. So they might be called neglect, right? The parents might be, sort of identified as neglecting the children, but there is some kind of substance use issue. And you all know that this crosses races, it crosses SES groups, except if you're middle and upper class and you're an opioid addict, you can have a nanny taking care of your children. So your kid doesn't appear in child welfare, but the opioid addict who does not have a nanny, her kid is going to appear because somebody's going to call CPS on her or something like that. Okay. So we got that problem. And we also know that when they come in earlier, right, and stay, the outcomes look worse. So that's another reason. I want them out by 6 months, not just because of what we know about sensitive periods, but the longer they stay in, the worse they look. Now, there are some data, and I'm going to talk to you all about Fred Wilson in a second. I'm a Fred Wilson groupie too. He has started to really look very carefully at what happens to these children's trajectories. And there is some evidence that babies stay in the system longer. They don't get reunified as fast. Even if they're adopted, that might not happen till later on. What I feel a little better about is that if we can get them into a pre-adopt home, which you hear a lot of child welfare agencies talking about, these are usually foster parents who are willing to adopt the children. At least the children aren't experiencing instability. I mean, a baby doesn't know, is my mommy a foster mommy or an adoptive mommy, and they don't really care. right? They just say, is this somebody who's going to change my diaper, who's going to feed me every day, etc., right? That's all they care about. So in some cases, we've got those situations where the children aren't moving, they just haven't changed status because of, how long it takes to get through the legal system. All right. This is one of the graphs that makes me crazy. So this comes right out of Child Maltreatment, right? The NCAN's book. So look at what happens to the under ones. Look at that big, huge bar of under ones. These are entries into the child welfare system. So again, my position is, why are we waiting till down here? Why can't we say there are a bunch of kids coming in during this time? What are we doing differently to address these high numbers so that we don't end up having these kids into care for a long time? Okay. Similar story in foster care, right? If you think about it, you're a good social worker, you pay attention, you look at your kids, you know that little people are more vulnerable, you're going to make the decision on one of those decision trees to bring that kid into care, right? Makes perfect sense. The problem is that we're bringing a lot of them into care and they are staying in care. And what we also know is that a lot of them are going to adoption. Look, 49% going to adoption. We're not really working with their parents to bring them back home. And I would submit to you some of that is supply and demand, right? I'm an adoptive parent. I know. I go to the agency. What do I want? A cute little infant. That's what I want. And guess what my social worker told me? That's not how we do it in DC. She said, you are to service our children. This is not about what you want. And I was like, whoa, okay, I got it. And I ended up getting 2.5-year-olds. They were still young, and it's funny because my social worker was in a group that I was doing of social workers where I was talking to them about this very thing, about young children and child welfare. And she said, I got 2 children for you. Don't worry about it. Right. So she kind of knew that I was into this, but the message was, you are here to serve our children. We're not here to give you what you want. But most people want a cute little baby. So 49% of the kids go to adoption instead of what I would argue we could do to keep them in their homes. Okay. Let's talk about racial disproportionality a little bit. So this comes from Lonnie Berger, who again is another person that I follow around, read his stuff. And he did this paper where they put this graph in that says that half of Black children in this country will get a Child Protective Service investigation. Half. And then we wonder why people say they want to abolish the system, why it's so bad for Black children. There is no way in the world that half of Black children are being maltreated by their parents. But half are going to get, and this is where they talk about the surveillance, right? We know in the United States, there is a high correlation between poverty and race. A lot of little Black children are poor. So yes, they are going to be surveilled. They go to public hospitals, they go to Head Start and early Head Start and childcare in poor communities. They are surveilled. And who calls CPS for little kids? Y'all know who's the highest? School, for the teachers call for the school-age children. Who calls for the babies? Healthcare. The doctors, the pediatricians call for the little babies. And they, have their licenses and things like that that they have to worry about. So these children are surveilled. They end up having investigations. It is true. But what happens when they come into care? All right, and I'm sure you all have heard this. Black kids, second only to Native American children, who we still don't know enough about, and their outcomes are pretty bad overall. And in child welfare, we need to really be paying more attention to these children. Part of the reason we may not know as much is because, they're governed by a different set of laws and policies through the Indian Child Welfare Act. but African American children are only second to those children in terms of their victimization rates. But the problem, of course, and I mentioned to you all that it's the medical professionals who are referring little kids. That's one of the things that they think is driving the disproportionality. So we can think about, okay, one pain point might be to think about who the referrers are and go talk to them about, do you really need to refer a kid because the mom has no heat in her apartment? Do you really need to refer a kid because the mom has no car seat and no crib? I mean, yes, that's a worry, but does that dictate your decision to call CPS? But part of the problem, as you all probably know, is CPS has become our go-to. We do not have the infrastructure in this country where there are a variety of community services that physicians can know, or nurses, or hospital social workers. I know if I call this system, they will take care of this family that doesn't have heat in the middle of January or March, because it's cold here, right? They don't have heat, that there's a system that will help with that. So CPS has been our go-to, which is not fair to all those social workers, and it's not fair to that system that doesn't even have enough funds to take care of the ones who are really maltreated. All right. So anyway, we also know that African American children are more than twice as likely to get maltreatment substantiation, right, which is different from referral, right? That's a social worker saying something did happen, but also foster care placement. The fatalities are higher among Black children, and then they're overrepresented in foster care. And that's been the big problem. That's what everybody's fussing about all the time. And it is real. You don't have to ask the question anymore, is there racial disproportionality in child welfare? We know it. All you got to do is look at the data. Black children are overrepresented. The question is how, why, and where? How, why, and where? Those are the questions. But there's not a question about racial disproportionality. Other quick thing, African American young children less likely to be reunified as well. Okay. So there's such a thing as a racial disproportionality index now. So what it looks at is the number of children who are coming into the child welfare system of a certain race over the denominator is the number of those children in the general population. So when you look at that, there is no question that African American children are more likely to be in this system. Again, this is not anything we have to wonder about. What we have to wonder about is how, when, and where. And one of the things that has been discovered is that it is really variable by state. Very variable by state. And guess who are the states who are more likely to have higher rates of disproportionality? The states that are not as committed to children's services and to services for poor families. So a lot like that, Southern Black Belt, Mississippi, Alabama, Louisiana, those kind of places, you see higher rates of disproportionality, right? So we have to think about what are the structural issues that help us to understand this phenomenon and to help us to think about what we can do about it. Okay. Geography is important, family context important. One of the things we've seen is that children who are exposed to substances prenatally, who have to live in postnatal substance using household, that gets children in care, Black children in care a lot, and child welfare policy. For example, if you have a child welfare agency that's really focused on reducing this monitoring, looking at, are there differences, are there disparities between what the outcomes are on that big, huge, complex chart I showed you all for kids who are Black versus white versus Latina versus Asian? Are we doing something different? Can we train our staff? Those agencies tend to have lower rates of racial disproportionality. So again, we kind of know what to do. We know what the risk factors are. The question is whether we're interested in doing it. All right. I'm not going to go through this bullet by bullet, but you all know this. If you look at the outcomes for poor and minority children in this country, they're pretty dismal, right? Just dismal. If you start to think about the outcomes of being poor, being of minority status, and being in the child welfare system, well, you got even worse outcomes. So some of them that I put up here are like growth faltering, right? Which we used to call failure to thrive, right? You see a lot of these young children not growing. They go to the pediatrician sees that they're not growing, but what happens after that? Well, call Child Protective Services, right? And I remember in one situation, I got a referral from a pediatrician. The kid had growth faltering, went into the house. The mother was just bound and determined to show me how much food she had in the refrigerator. She walked me around to her cabinets and her refrigerator because in her mind, she was a woman with some cognitive impairments. She thought to herself, the doctor was saying my child is not eating. Really, and you all know about this, there's a lot of research about growth being related to emotional sustenance, right? And in this situation, and in a lot of our situation with children in the child welfare system, it has to do with the parents' lack of an ability to be responsive and nurturing to their children. And their children will not grow. So, part of the work that we have to do again around this supporting parents, we call it parallel process in infant mental health, supporting parents to support their children is around helping them to understand that emotional support is as important as food. And I put it right out there to a parent in just that way. You're loving your child, you're holding your child, you're responding to your kid's cries is just as important as you giving that baby a baba, right? And helping them to think about it in terms of not that they're doing something wrong, because I never, I'm a clinician at heart. I lead with empathy. I'm looking for positive opportunities to talk about what they do. I talk about how much power they have to really put their children on a positive developmental path. And you can see the change. And they say, this lady's saying I have power, right? And you see them feeling better about what they're able to give to children. Okay, just quickly, I wanted to say a word about abusive head trauma. This is where we see a lot of fatalities from infants in the child welfare system. And you all know that's what we used to call shaken baby. They've got all these great public health things about, don't shake your baby, which is part of primary prevention. And I believe you're going to hear me say this. I think you should do multi-level prevention. So I'm not arguing that we shouldn't do these kind of things. But what the data has shown is that shaken baby comes from crying, incessant crying. And what infant do you know who's under 6 months of age that does not do incessant crying, right? And what happens is the parents get so frustrated because they're not able to calm the child down that they start going like this. So they're not thinking in their mind, if I shake the baby, the little baby's brain is pinging off their skull and they're going to have abusive head trauma and developmental disabilities. They are responding in the moment. So again, what are we doing to support parents who have the risk factors for that? Impulsivity, lack of emotion regulation. We know who they are. Are we just sending them to CPS? Or are we doing something to help them with that emotion regulation so they're less likely to do that? Those are the kinds of questions that we have to ask from a preventive standpoint. And again, I would argue we know what the risk factors are. We know how to do it. There's some beautiful research by Daphne Bugenthal about how to help parents who have those kind of risk factors. Get to them before they shake the baby. Help them know how to use meditation. Help them know how to do things like go hide in the closet or go in the bathroom and close the door. That's better than shaking your baby. But we don't offer that. as a matter of course for parents who might be high risk for that. Okay. And then we've got one of the things that really makes me so upset. NSCAW has found that 50% of the young children that come into child welfare have developmental delays. We have an early intervention system, and you all might know that there's part of the CAPTA law that says that every child under the age of 3 is supposed to get a developmental assessment. Well, what happened? This is one of the places where we've, failed in terms of our child well-being pillar. We don't have enough early interventionists to do it. We just don't have the support, the workforce to do it. So, and because social workers have tried to get it done and they can't get it done, it goes down to the bottom of their, list of things that they got to handle, right? This is something, again, we know how to recognize this, and we have an early intervention system that's designed to help children reach certain developmental milestones while their brains are still plastic. We have a system, but you talk to the early interventionists and they'll tell you, I got a caseload that's yay long. I may be able to get to this kid when they're 24 months of age, right? So again, what's our will? What are we really pushing for? We got the law, but when it comes to whether the policy is implemented, the devil's in the details. All right, so I'm going to shift to talking about what we can do about this problem. And I start with this because I'd like you all to look at the ROI issue, the return on investment. So this is from the Center for the Developing Child. So this is about the brain. But if you had an economist do the same thing, the graph would look exactly the same. What's it saying? That if you want to get the biggest bang for your buck, you want to do it early, right? You want to get to children when their brains are pre-wired to be able to respond to the environment in a certain way, okay? Now, it doesn't mean that people my age still can't change. My brain is still working, thankfully, but do I have to work so much harder to learn a new skill, to learn a new language, to know something about adolescence at this point in my career, right? I have to work harder. Whereas if we get to kids really early in life, we get a bigger bang for our buck, okay? So that's what I want to start with. And let me tell you what I think we should do. So obviously, I know Todd thinks this way too. You got to hit it from multiple levels. You got to do primary prevention, you got to do secondary, and you got to do tertiary. And just quickly, what's my first thing in the primary? Poverty. We got there is, and I have a slide in a couple minutes that has to do with poverty. We have to do something about child poverty in this country. And you all know, when did our child poverty rates really decrease astronomically? During COVID. When we started paying everybody that child tax credit, if you looked at the data on child poverty, it went down like this. Across every racial group, there were still disparities, but every racial group you saw decreases. And now what are we seeing now that we don't have that tax credit? It's inching back up, right? So again, we've done it. We know what to do. We don't have the political will to do it. Okay, so we got to do something about poverty, but then we've got these universal programs, like I mentioned to you all, the Purple Crying, the Stuff to Stop Shaking Baby, again, which I think is important, but we need to be getting into these families and working with them around some emotion regulation. On the secondary side, we're reducing risk for maltreatment. And what are your big three nowadays in maltreatment? Substance use, intimate partner violence, and mental illness. Those are our big three. So yes, you're going to hear me say there's a high correlation between maltreatment and poverty, but for little kids in particular, those big three, I call them poverty plus children, one of those three is often what gets the kids into the system. So we got to do something about those risks. And then obviously, we want to think about what happens to children who've already experienced maltreatment. How can we prevent it from happening again? What can we do to help them with their outcomes? Okay, So let me talk about poverty just for a second. This is a big deal for child welfare. It's a big deal for our country. We don't pay enough attention to it. But if you look at what happens with little kids, much more likely to experience poverty. One of my colleagues at Columbia says a child is most poor the day they're born. Most poor the day they're born. Her argument is that young families are poor. They don't have the money, they don't have good jobs, they haven't gotten good insurance, all those kinds of things. We know the data on this, and we're not saying let's support, let's put a safety net in for these young families. We can talk about TANF and all that stuff in just a second. Anyway, we know that little kids are more likely to be poor. We know that kids from minoritized backgrounds are more likely to be poor. I just want to say a word about Latin American children. Have you all heard of the Latino paradox? Have you heard of that? So the Latino paradox, for you, those of you who haven't heard about it, Latino children look just like, other poor children, right? Like Black children in terms of parent employment rate, their difference in terms of marital status, but a lot of their sort of demographics around economic insecurity, all that kind of stuff are the same. But their babies look a lot better than Black babies, a lot better. They're born heavier, they have fewer medical issues, they have fewer mental health problems. Some people argue that it is the beautiful child rearing experiences that they bring with them to this country that they use to parent their children, like much higher rates of breastfeeding than you see in poor African American families, much higher rates. So that's already setting your child off on a better path, right? But also better responsivity, things like that. What happens in the second generation? They start to look much more like little poor Black babies. So once they acculturate to this country and take on the child rearing, practices that Americans have, their kids have worse outcomes, right? So just some interesting stuff. If you all look up Latino paradox, very interesting things. All right. So we know that if you're poor, you're much more likely to be involved in child welfare. That has to do with surveillance and all that kind of stuff. Poverty, of course, across maltreatment types, but particularly for neglect. Particularly for neglect. And again, how are we defining neglect? By state, by jurisdiction, by social worker, right? Sometimes neglect is the basket, the waste basket category. Everybody goes in when you can't figure out what to give them, right? So how is neglect defined? But certainly there are a lot of cases that are not substantiated, right? You all know, I had a slide earlier, I didn't go through all of this, but half of the cases of neglect are not substantiated. So the question becomes, is this a question of poverty? Now, the ones that are substantiated, it's poverty plus, right? But the ones that aren't, what is our system of care that allows us to be able to support those families and children so that child welfare workers don't even have to deal with it? All right. I love this research. This is not my research area, but I love it. People who are policy folks have looked at state by state outcomes for children and state by state policies for children. And what do they find? Look at this. Every additional $1,000 per kid that comes to a child annually results in a reduction in child maltreatment reports, reduction in substantiated child maltreatment, reduction in foster care placements, and reduction in child fatalities. So what is that saying? Places that have expanded Medicaid, places that don't have these ridiculous rules about TANF, places that have more expansive SNAP programs, places that have more expansive WIC programs, you see this. Now, you all might say, well, what's the mechanism? I would argue from a family stress perspective, we're reducing the stress that families might have. But I'm also thinking that a lot of this has to do with the political commitment in a particular jurisdiction to all children, particularly poor children. And if you have that kind of commitment where you're willing to spend more state dollars to have a mother stay on Medicaid for the first year of her baby's life so that she can go to the doctors and get herself taken care of so she can take care of her babies, that you are a system that's more invested in children overall. So there's probably more early Head Start, there's probably more child care slots, there are probably more neighborhood supports, etc., right? So again, what does this tell us? Their geography matters. Where you were born matters. What kind of state you're born into matters in terms of your experiences. And I think as social workers, we have moved too far away from understanding these structural things. When I was trained, you always tried to see, can I get you on TANF? Well, it wasn't TANF then, it was AFDC. Can I get you on food stamps? It was part of our casework approach. Now we want to be therapists. I understand. We all want to be therapists. We all want to get clinical degrees. But what I say to my students is you are unethical if you are not asking a parent about that bottom of Maslow's hierarchy, right? If you're not saying, tell me, are you getting all the income supports you need, especially when I look at data like that? Okay, couple other things I want to say to you about I'm still in the sort of universal home visiting. All right, so you all know social workers have been doing home visiting since we began, right? 19th century, not that we were doing them the right way with our gloves and all that kind of stuff, but we were doing home visits. Never did I think I'd see a national home visiting program in the United States, which says to me, we are moving slow, but we're moving. You all know Great Britain, other countries in Europe have had these kind of home visiting programs forever. We now have a national home visiting program for young children and families. Not the best in the world, but it's certainly a start. All right, here's the worry I have. One, you can only get money in a state if the program meets some evidence-based criteria. And I don't know if you all have ever looked at those criteria, but it's not easy to get to be an evidence-based. You have to have like either 2 randomized controlled trials or a very high quality quasi-experimental trial. You have to have 2 outcomes. You have to have a replication. It's not easy. I've tried to help programs get there. It's really, really hard. And they don't have to be published in a peer-reviewed journal. They could be a gray paper, but they have to be one of those really gold standard-y kind of studies. That's one problem. But the other problem, I was telling Todd about this earlier, look at the boatload of things they have to do. And if you think about these programs that have the evidence, they have evidence on what they were good at, right? NFP, Nurse Family Partnership, was good at getting nurses to go in there and helping with health outcomes and preventing children from getting injuries and all that kind of stuff. When were they even worried about economic goals, right? Or PAT, that parents and teachers, which was good at this screening for developmental delays and things like that. When were they good at connecting families to health care? But part of the deal with McV was that all the programs had to provide services in all these areas, not just to provide the services, there were performance metrics that they had to show, report on every year when they got refunding that showed that they had done these kind of things. It's just hard to do. And somebody I know wanted to know about the home visiting data. I was saying to Todd, well, if you at Scale Up got to do all this stuff, it's going to affect your ability to do the things that you do really well. And my argument is we could decide based on a good assessment what a family needs. Do they need an NFP? Do they need a PAT? Do they need an ABC, which I'm going to talk to you all about a little later? And then we give them that and we'll have better outcomes. But what states do, they often will decide we're just going to do these three and they'll just split the families between those three. And they won't think about, for example, are the three that we've chosen the best for our Latina families in this community, or our East African families in this community, or our Native American families in this community? Do we even have any evidence that these particular interventions work the same for those families? Right? So we're just going to stick them wherever we are. So again, the devil is in the details. I think we've made a good start. We're going in the right direction, but there's a lot more work we have to do. Okay. This is really not about McVie as much as it is about my sort of belief about parent-child interaction. And I just said, I should not put this slide in, but then I said, I have to have an opportunity to talk about this. So when I was a young social worker, I would go into the house, sit on the sofa with my little notepad, ask a bunch of questions, write the answers to the family, ask another bunch of questions, give a lot of advice, tell them about child development. I cringe at the thought. We know that that kind of work gets you no change. Makes me sad because I feel like all that time I was doing this and no change. What we know now works is experiential interactions, right? That as home visitors or as clinicians, if you're seeing the kids in the clinic, you should not be sitting there asking moms a lot of questions anyway. You should be using your good observational glasses to see what's going on between her and the child. But the other thing is that you should be a mommy whisperer or a daddy whisperer, right? We've learned this from all kinds of programs, and I'm going to show you a little clip from ABC, that we become the coaches. We're on the floor. And, I've had supervisees who said to me, Brenda, I'm not getting on the floor. The place is filthy. I said, bring a blanket. Do something. Be on the floor with the mother and the baby. Help her to know what she should do while she's in interaction with her child. And you never say, and the interventions that show really good findings say this, you never say, oh, you're doing it wrong. You look for opportunities to say, Mommy, look how when you smiled at your son, he gave you a big smile back. He thinks you're the best mommy in the world, right? You see the difference. You're changing behavior by being a part of the intervention. And so it's all relationship based. It's the relationship between the clinician and the parent, and it's the relationship between the parent and her child. And you don't have to do it with play. Some parents don't like play. You can do it with music and dance and feeding routines and bathing routines. You can use all kinds of different routines, but the idea is you're with the mom, emotionally with her in a way that you help her to know what to do when her child is in front of her. That's very different than some of the didactic stuff I would use where I go say to mothers, here are some alternative ways to discipline your child that don't require you to spank them, right? She can tell me that back, but will her behavior change? No. But her behavior will change if I say, oh, Mommy, I can tell he's driving you crazy. I can see you want to slap his little butt. Is that all we can do to get what you want? What else do you want him to do? You want him to stop crying? Think with me about what works for you other times, right? So it's a different approach and it's all about experiential stuff. So what do we have? That kind of interaction gets you better outcomes for parents, right? And guess what? If you use videotape, which, I'll be honest with you, when I did ABC, I said, these parents are not going to let us videotape them. I was dead wrong. They loved it. They sent it to all their relatives. They wanted their relatives. One lady would have her kid dress up every time we did the video. They loved the video. And we gave them this beautiful montage at the end. This is what Mary Dozier tells you to do at the end of ABC, of all their best moments. But what does it mean for intervention? It means that you get to show parents their interactions. They can see it and they go, they look at it and they change their behavior because of it. And by the way, it's a good supervision tool too, because you can bring it in and you can see when you're working, because you can't go out to everybody's home and watch what everybody's doing. It's a good supervision tool that you can use to see how home visitors are responding. All right. Another important early intervention is early care and education. And again, I will tell you all, when I was a young social worker, it was not on my radar. And my supervisors never said to me, get the kid into an early care and education program. I went to a very clinical school. I went to NYU. It was all about Freudian kinds of diagnoses. And I'll give you an example that I'll never forget. I had a case of a mom who was on methadone, a dad who was on methadone. The dad was a great caregiver. The mom, she was young. She wasn't quite where she needed to be. 3 beautiful children. The middle one was 3, zero language. And my supervisor's assessment was that the kid was electively mute, which could be true as a result of trauma, but I just didn't see trauma. This dad was really very into his kids. The mom, not quite so, but you only need one parent. And this dad was fabulous. Well, as it turned out, the child had a huge language disability. And it was just by happenstance that somebody, not my supervisor, said to me, maybe you should get this child a language assessment, right? So I'm just saying that there are ways to think about these families that help us. And one important way is to get them in early care and education. That should be the first thing on every social worker's list when they get a case like this. One, it gives the children an opportunity to experience that kind of care that we think they need in the first few years of life while we are working with these parents to get them where they need to be. It gives them an opportunity for stimulation. And if you send them to Early Head Start, which is a 2-generation program, there is some support for them as well. There's a family engagement person who'll make sure they get their income supports. So to me, this should be like thing number 1 on our list of things for these kind of kids. All right. I just want to show you, I'm not showing you a lot of my data, but I'm going to show you data from this study and from one other study. But this is when I was doing an evaluation of pre-K in Baltimore City. And I don't know if you all know about Baltimore City, but it's been criticized as one of the worst states in the city because of their crime rate and their opioid use rates, et cetera. Very high risk families. So we were looking at pre-K. And what do we get? Because these are, very low income children in lots of struggling neighborhoods. Pre-K helped them with early math, helped them with receptive vocabulary, and helped them with early literacy on these are, tests that everybody uses to look at kids' academic outcomes. Not so good on executive functioning. So what's executive functioning? It is what Jack Shonkoff calls your air traffic control system. You can tell he likes metaphors. Toxic stress, air traffic control system, right? It's what the part of our frontal lobe capacities, like I always say to my kids, use your front brain. This part of the brain helps us to problem solve, to sustain attention, to delay gratification, all that kind of important stuff, right? This preschool program was good at getting children to learn letters and learn numbers. This is the stuff that leads you to critical thinking. And we live in a society where if you don't have critical thinking, you won't have a job because AI is taking over all of this stuff. I mean, yes, it's important for children to learn it, but in the long term, it's more important for this. And this wasn't happening. So, this is one of my worries about what we're doing. But another worry I'll just show you is that we got some money to do just a small sub study where we did home visits on 1/3, randomly selected 1/3 of these 1,000 kids that we were looking at. And we asked mothers about their trauma history, because obviously I'm going to stick trauma in whatever research I do. So, what we found was that if mothers who had experienced high rates of trauma, if they had experienced high rates of trauma, their children did terribly on the early literacy test. So, what does that say to a person like me? That this is a good universal. Let's get these little poor kids into early care and education. Let's get them into pre K. But for children who come from the higher risk backgrounds, this just is not enough. It's just not enough. We need to do more, right? And there was something on the slide before that I didn't go over, that if you couple a poor early care and education environment with a poor home environment, you're going to get worse outcomes, right? So we did a class, which is the assessment where you look at teacher um, behaviors. And we didn't include this in the paper because we only, had it on the teachers in one group and it just got too confusing. But they look pretty bad in terms of things like nurturing and responsiveness, the kinds of things that we're trying to get parents to do. The teachers were sit down and those kids were compliant and they sat in their chair, 4-year-olds, right? So they got the, the kids in the middle. But the kids who were struggling from families who had high trauma, they didn't get. So what this argues for me is pre-K is good. It's a good universal. It raises the boats, but we need to do something different for these kids coming from those families. Okay. One of the things I just put up here, we're doing a study on this now where we're looking at mental health consultation to these schools and how to help these early childhood centers. This is a big deal now in the field of infant early childhood mental health. Let's help them understand social emotional issues a little better. All right, let's get to secondary prevention. So there are beautiful secondary prevention programs, beautiful evidence that we have. You can reduce kids' behavior problems, right? Like family checkup at Credible Year, Chicago Parent, all about parent management. You can help kids have safer environments. These really are about the risk factors that parents have, like mothers and babies is a great program that has found you can reduce maternal depression in a home visiting space. Mom Power has a lot of parents with substance use, parents under pressure, parents with substance use. We've got data that says there are ways we can do this. A lot of these programs that are addressing the parent risk factors, again, these big three, substance use, mental illness, IPV, really focus on helping the parent with regulation and all those kinds of things, and work with like a treatment program or something like that, but you can do it in the context of these secondary prevention programs. Now, I'm going to tell you a little bit about attachment biobehavioral catch-up because that's the one that we've done, and it is short, 10 weeks. And one of the things that some people have argued is, why can't we use that for family time and visitation, right? What are we doing for family time and visitation? Still, after all these years I've been in the field, I started out as a foster care worker, one visit a week for an hour. I thought we had gotten past that a long time ago. If we really are serious about reunification, we are not just asking, did you go to a parenting class? And just last week, I had a mom calling me up on the phone. Miss Jones, can you call my worker and tell her I finished my parenting class? I just almost blew a gasket because I was like, why does it matter? We know that parenting classes are meaningless. Meaningless. Yes, the parent will say, I shouldn't hit my kid. Are they going to hit their kid? Probably. Yes, we know that parents should say, I should make sure I pick up my baby when they cry. Are they going to say the baby's spoiled and leave them there? Yeah. Right? So parenting classes to me are meaningless, and I could not believe I had to call a social worker, because if I didn't call her, the mother would have been in trouble. She was a substance using mom. She was trying to keep her baby. I had to say parenting class. But I thought, what a waste of her time and my time. Right? So I don't want a parenting class. I want an experiential, home-based, hopefully, parent-child interaction approach. And it's just not ABC. There are a ton of them, right? Promoting first relationships is another one, right? Find is another one. And what do they do? I mean, yes, it's manualized, but Mary Dozier, who's the developer of this, will tell you the manual, I did it for NIH. But what does she say matters? This focused experiential intervention using coaching, which she calls in the moment commenting, right? In the moment commenting, where you are right there with the parent. You're saying, oh, mommy, look how you are responding to him with that toy. This is going to help him know he is the best person in the world, right? So you connect it to what it gets there, and that's what you do. And she argues that the in the moment commenting is the secret sauce, right? But that's her approach to coaching. Everybody else has something different. She also uses videotape in her work. And what does she have she's done it with adoptees and kids in foster care and children in alternative response. These children are CPS kids who I call them the gray kids, alternative response. And what she get? More likely to be securely attached, more appropriate diurnal patterns of cortisol. Mothers show more sensitivity, and infants less likely to have disorganized attachment. And disorganized attachment, you all will remember, is that category that relates to children being maltreated. Okay, so she's got these beautiful findings. And we did it in early Head Start with Latina mommies, and we got beautiful results as well. Improved sensitivity, less intrusiveness, more sensitivity. And then Kathy Hirsch-Pasek, who is a language person, said to Mary Dozier, you're doing all this sensitivity. We know that language is about social interaction, parents responding. You're probably going to get language outcomes. So we said, we'll try. And look at this. We coded our parent-child interaction videotapes, the pre and post, looking at language outcomes. So we looked at all those things that the language people told me about. I didn't know anything about: number of utterances, different types of words, how many words, the type token ratio, that mean length of utterance, all those things. And we got positive impacts for 6 out of the 8, and 1 was a trend. This is not even a language intervention. It's an intervention to improve sensitivity. It's 10 weeks long. 10 weeks long. Took us 2 years to code the data, but we got the data. And look at this. And the other thing that we found is that it was the mutuality that we found between the mothers and children post-intervention that really was the mechanism by which we got these better language outcomes. 10 weeks. 10 weeks. Putting it into family time, where we're worried about visitation. Instead of taking parents to McDonald's, to the godforsaken play place where nobody can pay any attention, do ABC. And actually, I don't know if you all have heard of Carol Schofer, but she's one of these really whippersnapper kind of lawyers who's been suing all the child welfare systems all over the place. Well, people change in their old age, and she's been in the field a long time. So now she's trying to do something, and they are actually implementing ABC as part of family time and using foster mothers to deliver it. Because Mary Dozier said, you don't need an MSW. So they're using foster mothers to deliver it during family time. Okay, I'm just going to take a second out and show you all this video clip from Mary Dozier. This is our study, and I'm just show you a really short clip of a mom before and a mom after. So let me do this really quickly. So tell me what you see. Hold out. She's not talking. What else? Not touching. She's sitting back farther from the baby. And what about the baby? He was a little frustrated. He was giving a little bit of, come on, mom, what's going on here? Now look at this 10 weeks later. Already, what do you see? She's got the baby in her arms for a change. She's talking. You see that's following the lead. She's paying attention to what the baby does. 10 weeks. 10 weeks. And I was a naysayer. You know, I was trained as a clinician who did psychodynamic work. I said, no way. And I was wrong. I was happy to be wrong for a change. All right. So let me go back to, what did they tell me to do? Slideshow from current slide. Oh, I did it. I'm so proud of myself. Okay. Yeah, I'm so proud. So proud. Okay. So I want to go to the third part, which is basically infant early childhood mental health interventions. All of the interventions that are these short-term parent-child interactions are grounded in infant mental health work. They all are. It's all about approaching this from a relationship perspective, dyadic, triadic, you as the clinician being with the mom to help her be with her child. I notice I say mom, not many of them have been validated with fathers, which is a shortcoming of the literature. And we know, for example, with a lot of moms who are struggling with substance use, it's the dads who end up taking care of the kids or the grandmas. We have a lot of work to do to see how you can adapt these to other people. But these are some of the things that come across, right? Relationship with caregiver, that's what you're working on. Parent-child interaction, you become the voice of a child. Because a 3-year-old has language, but they can't say, I need you to hold me when I get scared. So we have to be that voice for the child, for the parent. Alicia Lieberman talks about this a lot, reflecting. Any of you who know this work, you know they talk about ghosts in the nursery. This came from Selma Freiberg, who started her career in Detroit. Social worker. You all know the famous paper, Ghosts in the Nursery. Anybody ever read that famous? It's a famous clinical paper in infant early childhood mental health. And Selma Freiberg was a social worker, and she was the mother of this work right here in Michigan, so Detroit. So remember that. But it's a beautiful way of thinking about what do parents bring to their interaction with children that are residues from how they were taken care of. And so part of the work is helping them to come to terms with that so they can decide, and they'll say it out loud, I want to do different with my child. They'll say it out loud. Now, the Mary Doziers of the world would say, it's fine and dandy to do all that. That's great. But again, the real work is when you're on the floor trying to help her be with her kid in a different way. All right. So it's all these things that you want to do. And the one I want to bring up is CPP. It is a beautiful intervention. They have gotten it down to under a year. They used to, they were psychodynamic people too, believed you needed 2 years. But, to keep up with the way these short-term interventions are. They've gotten it down to a year, and they have worked with parents exposed to IPV, right? So they're only taking the most high risk, and they get decreased behavior problems and PTSD symptoms. They get reorganized early attachment relationships in infants from maltreating families and enhanced parental sensitivity. So this is coming from Alicia Lieberman's work, but Dante Cicchetti's shop in Rochester has also done it. Beautiful outcomes on working with maltreating families using this kind of approach. Okay. Zoom is not responding. Okay. Let me see if I can get this going down. No? All right, let's try it this way. Uh-oh, I'm struggling. Oh, there it goes. Okay, so I'm gonna try to bring this together now. And what I wanna say to you all is that what I would love to see is an early childhood system of care located in a child welfare program. Some people say that's a mistake, Brenda, because parents see child welfare so negatively. So if it doesn't have to be in the child welfare program, but it should be funded by this funding stream, and it could be like they do in DC, where they have what they call community-based collaboratives, and the collaboratives are in the community, funded by child welfare. Families don't know it, but they try to do this same kind of thing where they're given this sort of wraparound system of care for the vulnerable among us. And I would argue, and this is one of the problems I have with the DC model, I love how they're doing these collaboratives, but they're not focused on the little kids. And I want some focus on the little children that really brings together pediatrics, like Healthy Steps. They now have this great program where you have a developmental specialist, social worker attached to, they're trying to hit every pediatric low-income facility that they can, where you're including Head Start, those kind of programs, the parenting programs we have, the early childhood mental health programs, and obviously support for income and child welfare. Project Launch is an example of that, where it's mental health, including, look at how they're defining mental health though. Consultation and early care and education, enhanced home visiting, family strengthening, all that kind of stuff. So it's not just seeing a kid in a clinic. And this is the other project that I want to tell you all about that I am so happy that 0 to 3 is doing. It comes from a lawyer again, a lawyer who used to be suing child welfare, who's saying, let me do something. And they have created these great programs where they assign somebody to a judge, and it becomes a baby court, with the idea that we're gonna move these children more quickly to permanency by, one, having infant early childhood mental health people, by having substance use people. And if you look at, like, I just have some impacts-free services, but there are also some data where they compared the kids to INSCAW and see that they can get them to permanency faster. 95% of children needing early intervention getting them. 90% of children needing child-parent psychotherapy. That's the one I was telling you all about, getting them. 74% of parents needing substance abuse treatment, getting it within a week. 80% of parents needing mental health services seen within 30 days. These are the kind of findings. They're attaching this social worker, care coordinator to the judge, and the judge can just say, you go handle that. They have these programs all over the country, certainly not as many. We just are getting one in Baltimore that's focused primarily on the substance-exposed children, and I cannot be happier. But this is the kind of system of care that I'm talking about. I would love to see it happen not in this siloed way where, you know, we have a baby court and we have infant early child mental health. I'd like to see it in a more, you know, sort of community-based way, but we haven't gotten there. All right, just quickly, I just want to say a word about Family First. So, yay, Family First, okay, first of all, because you all know, what were we doing with child welfare money? Where was most of the money going? Foster care. That's it. Somebody's been taking a child welfare class. Foster care. Finally, not finally, it's been gradually, advocates have been saying, stop spending all this money on putting these children in substitute care. Let's put some money in sending them home to their relatives. Okay, we got that. Title 4E waivers, remember, like in Chicago. Let's look at, can we give foster parents, kinship caregivers some money? And then we got Family First that said, let's take some of this money that we've been spending on foster care and put it in prevention. So the idea is good. What do you get? Foster care prevention and family reunification programs, mental health, substance abuse, in-home parent skill. There's even some money for these great programs, parents and children in substance use, in these treatment facilities, which I think is the only way you're gonna make these moms be able to take care of their children, have residential programs where they can bring their young children, right? Even money for that. Great, it's like with home visiting, we're on the right foot. But what are the challenges? Evidence-based. And if you all look at McVie, I showed you all, we got about 25 programs. They're like 8 that have passed muster for Families First. ABC that I just showed you couldn't get into Families First, even though they've worked with the alternative response and foster parents, because they had an active control group. And for you all who aren't researchers, a control group that's non-active is one that gets nothing. An active control group is one that gets a little something. What's more rigorous? Comparing it to a program that gets, where you give control families a little something. That's more rigorous, and she could get approved because of that. Now, I have heard that she's been arguing and fussing and yelling and everything, and it may change, but that kind of rigidity in terms of who can get access to the funding to be able to provide services has been a challenge. And some argue that these programs also have not been adapted for every cultural group, so that might increase racial disproportionality. The other problem is that it's generally applied to families where there is imminent risk for removal, which means these are your highest risk families. So for the upstream cases where there's poverty, like those neglect cases that I've been telling you all about, they don't get as much of the money. Half of the money is going to these imminent risks. So again, that might be one of those, you all call them unanticipated effects of a policy change that might cause problems. All right, I'm gonna stop with this last slide. I'm gonna skip some of my stuff and say, this is from a paper that a colleague, Charlie Zena, and I just wrote, where it was a racial disproportionality journal issue. And they asked some of us to argue, actually it wasn't racial, it was abolition, that's what it was. But abolition was discussed in the context of the racial disproportionality, right? That we should get rid of child welfare. And Charlie takes a harder line than I do. He really thinks it's unethical to be arguing for abolition. I think we need advocates who push the envelope to get us to really think about reform. And I feel like, just like, the people who are saying we should abolish jails, they're making us to pay more attention to what the conditions are in jail. So I think they serve a purpose. But we were basically saying that we were not in favor of abolition, but this is what we wanted to see for little kids. So we talked about really centering these babies, because we know epidemiologically they're at higher risk. They come into the child welfare system more, they have more worse outcomes, not only in terms of their trajectories, but their developmental outcomes. We talked about the import of services focusing on those parental risks. We know what they are. They're the big 3: IPV, mental illness, substance use. You can't ask a mom who's a substance user, did you go to a parenting class? That's not what you ask her. You can't ask her, did she go have her urines checked? You get to what is leading to the substance use. You get her into treatment. You help her think about how her substance use is affecting her child. You put her in a program where you're working with her to be with her child in the best way she can be, right? So focusing on those things. We gotta pay attention to the stuff that we used to do in social work, which is income supports. We have to do that. These families are being, I had a mom just recently, I told Todd that, I don't do clinical work anymore, but I have this big study and we made it community engaged. And so we're working with families all the time. This mom had 5 little boys, 5, all under 6. And she was about to go deliver the last one, the 5th one. She was a single parent. Who was going to take care of her kids while she was delivering that 5th little boy, right? She had nobody. She was a former foster kid herself. She just knew that they were going to come take all of her children. We found some church that would give her some money to pay her family child care provider to watch the kids so she could go deliver that 5th little boy in the hospital, right? That's the kind of thing that was part of good social casework that I hope we never, ever forget. Monitoring and addressing racial, ethnic disproportionality and disparities, right? Bringing people in with lived experience, helping them to think about what would it take to help me do better with my child, right? Prevention, prevention, prevention on all those multi-levels that I talked to you all about. And then, which this bottom one we put in there, but it's been talked about for a long time, back to Pelton and all those people whom you all might remember in child welfare, right? Can we have a more targeted child protection system that's focused on the kids who are abused sexually and physically, and those children whose neglect is severe, so that we don't overwhelm these systems. You see the big, huge caseloads and all this kind of stuff. And so we can say to them, though, that these other children will be taken care of in some kind of community-based early childhood system of care. That's what I'm spending the rest of my career yelling and screaming about. I'm hoping you all are young. You'll keep us moving in the direction we need to so that little kids will get the support they need to have good developmental outcomes. So with that, I'll be quiet and open it up for any questions.
Thank you so much, Brenda. We do have about 15 to 20 minutes left, so why don't we go ahead and open it up to folks in the room if you have questions for Dr. Harden, Jones Harden. Yeah, please. If you could use the mic, that would be great. There's some folks still online.
Since I am a mic, I'll use the mic.
All right.
Can you hear me?
Yep.
Mike Flannery, class of '86, 40-year history of doing home health care, primarily with the elderly in the home. But I saw it A to Z, 0 to 110. Brought up an example of the mother just now, 5 children, 5 young kids, boys. Was there a discussion as to how and why that happened in the first place, since there was no other, it sounds like no other, not enough information, but it doesn't sound like another adult involved.
She was a former foster kid, and so what we have found a lot with foster, first of all, there's a higher rate of teen pregnancy among foster kids. It's really going down in the regular population, not so among former foster children. And you all know that a lot of them who transition out of care end up in the homeless population, end up all that kind of stuff. So she was really kind of out there in the world by herself. She had a partner, but he was abusive, and what had happened right before this was She had a child protection referral. I don't know who made the referral, but it was because of the intimate partner violence, and she was told that if she wanted to keep the 4 that she had to get rid of him. And to her credit, she did. And you all know that doesn't happen all the time. It doesn't happen a lot of the time, but she did. So it wasn't that this was planned for her to be by herself delivering this baby. It's what ended up happening really because of the child protective referral. She just did not want him in the house because she didn't want the risk losing her children.
I think I meant what was the intervention in regarding.
Oh, now she was the intervention we were doing, she was in one of our studies. And as I told Todd, we have turned this study into a community engagement study. So when a parent says, I have a need, we try to address it, even though we're not assessing that. So this was a mom who said to us, she called us up and said, I'm scared. She was like 8 months at the time. I don't have anybody to take care of my kids. What am I going to do? They're going to put them in care. And so we took it upon ourselves to do that. So it wasn't an intervention. Yeah. About which. No, but part of what we did was found a program. It was a community-based program that would give her not a short-term loan. It was like, one of those things where you just give people crisis funding. And part of the intervention that we got her in was the crisis funding, but she had to participate in a series of home visits with this program that focused on parenting and her whole, situation. So they just didn't write her a check. They gave her that support.
Ronna, go ahead.
Well, first of all, thank you so much for that brilliant talk. I am a faculty member here, and I will add that I'm a Brenda Jones Harden groupie. I've been reading and teaching your materials for over 2 decades, so it's really a pleasure to hear your talk. And you mentioned a lot of different aspects to the system and all the different ways. I think I agree we have very strong actual evidence-based practices, but unfortunately completely lack any political willpower whatsoever to fund or support those services. And I was very disappointed when we had the opportunity to pass the childhood tax credits in the immediate aftermath of COVID, which would have been a huge thing for kids in this country. And 2 Democrats stood in the way, Joe Manchin from West Virginia and Kristen Sinema from, I know, okay, so I'm
with you.
So what do we do? I mean, I guess I know that's not an answerable question, but I'm curious, you've been doing this for a long time. What do we do when there is no political willpower to help kids and families, especially poor people in this country?
Yeah, I'm with you. I'm with you on this issue. I go back to the social work ethics, which says that part of our responsibility is to be advocates, right? And yes, I'm not gonna give my career over to being an advocate. I love what I do. I love being around families and children. I get a lot of gratification from it. But by the same token, I feel like I have a professional ethical responsibility to advocate for the kind of structural changes that you talked about. I'm not good at it. I don't know how to do it. I've spent my career working with families and children. But I am going to be a part of a larger group that does. For example, I just finished being president of 0 to 3, which is the organization that's been working on infants and toddlers for all these years. We have a Strolling Thunder Day every May where, take off Rolling Thunder, where we show up in the offices of Joe Manchin and all these other people. We take big baby bottles. We take little, briefs for them to read. And they're very strategic at having certain people go, like Helen Rakes, who's one of our board members, is from Nebraska. They send her to the Nebraska Congressman's office. Or Walter Gilliam, who's now the chair of the board, they send him to the Kentucky office because he's from Kentucky. And we use that as an opportunity to try and get people on our side. Rosa DeLauro, who is Pistol. I don't know if you all have ever seen her, but she's got to be 80. She's got purple streaks in her hair, and so she's head of our baby caucus, and she does a lot of fighting for us. So we have seen, and this is what I tell my students, and my advisor told me this, if you want to see policy change, you really have to be in it for the long game. It takes 7 years for any kind of change to happen. And unfortunately, we live in a society where poverty matters because we gotta have the haves and the have-nots. This is just the kind of country we live in, and you have to understand that and know what you're dealing with. But then you have to say, can I move this along? And for me, that helps. When I spend some of my time working on shifting policy in that way, fighting for things. You get small steps and you say, all right, we've gotten this far. Like, I remember when we didn't have a home visiting program. I remember when we didn't have an early Head Start program, right? I remember when we didn't have Family First, when we were spending all this money on foster care. So I guess, that's how I get through it. I think, how can I put my energy into something bigger than me that can move? The collectives and the collaborations and the community groups that are working. Like, I'll give you another example. You all know they've been trying to get rid of Head Start for 20 years. And every time they try, those parents, those alumni get out there and say, you're not going to do it. And they have not gotten rid of it yet. I know they want to, and they tried to send it to the states. So I guess what I'm saying is, no, we don't have a country that has the political will, and I don't think we ever will. I hate to sound so jaded, but I don't think we ever will. But we can push them to be responsive in certain kinds of ways. And I think if you look at it in the long game, you can see the kind of small progress we made, and you need to keep pushing, keep pushing, keep pushing.
Rita, go ahead.
Yeah, I have tons of questions, but I will ask one. So you were saying that in Head Start and Early Head Start, they do okay at the middle, but for the most disadvantaged families that don't do as well, and there's some interventions that's starting to do that. Is that happening at the national level, or is that something's happening one state at a time?
Okay, so the study that I was showing you was pre-K, which is different from Head Start, right? Pre-K is usually part of public school, and it's, 9 to 3. No nap for 4-year-olds, by the way, which drives me up a wall, but that's another story. Because they feel like, and in some jurisdictions, they will say you cannot let these children nap because it's supposed to be instructional time. But anyway, that's another story. Head Start is 2 generation, so the outcomes are different. Now, you may have heard that the Head Start impact study didn't get great findings. Part of it had to do with the fact that we don't have a control group anymore, right? The control group goes to pre-K, they go to something, so we don't see it. But the data are pretty clear from pre-K that if you want to address these other things, family issues, kids' behavior problems, you need more than just the academic pre-K program. And that was in the study I did, but other people have found the exact same thing, that you gotta either provide some kind of mental health support, or you gotta have some kind of family support, what Head Start is trying to do.
a student here in the Children, Youth, and Families pathway. I'm really interested in all the community-based programming that you were talking about. I think those are all so interesting as I think about my career and things I want to be involved with as a social worker. I guess my question is, from what I've seen and what I've heard, a lot of these programs are more early intervention once a child has already had an interaction with the child welfare system. That's how they get referred to them and referred to these programs. And I guess my question is there a way to make these programs that are community-based voluntary, and how do you get buy-in from parents in kind of a climate where a lot of parents don't want to be told how to parent their children and aren't open to feedback and things like that?
Yeah, actually, most of the programs I was telling you are not situated in child welfare, and you don't have to have a child welfare referral to get into these programs. They are more secondary but the question is, how do you get to the family? So what they've done in New York, for example, they've got a whole list of these programs. They, kind of did what McVie did. They got a list of them that families can go to, right? So they will refer them, but they also have them in the community. So you can be referred to these programs by Early Head Start. You can be referred to these programs by the Healthy Steps person at the pediatrician's office. You can be referred to these programs by somebody who is working with an older child in school and sees that you have a young child. So Healthy Steps, for example, is in the pediatric office. ABC is in community-based program. They don't call it ABC, they call it Power of Two in New York. CPP you can get from infant early childhood mental health programs that are usually in mental health clinics. So many of them do not require you to have a child welfare referral. Now, the funding stream is important because child welfare has money, right? Well, they don't have a lot of money, but they have a funding stream. So some agencies might say, we're only going to take these kids because of that. But in Maryland, for example, Healthy Families and those home visiting programs are part of the Department of Health. They're not even related to child welfare. And Maryland just got, talking about policy change, just got Medicaid coverage for parent-child interaction approaches. So you don't have to be seeing a kid and have a diagnosis and all this kind of stuff. You can get Medicaid coverage in a mental health program for doing this kind of parent-child interaction, which was a big, huge win. Took a long time, long game, but they got that approved in the state of Maryland. So I think there's a move to not have them situated in child welfare. I mentioned DC, they've got these community collaboratives. So part of their prevention strategy that was part of Families First was they have these metaphors: front yard, front porch, and front door initiatives. And so families don't really know that this is child welfare funding that's supporting that. So I think there's a lot of space for that now that wasn't there when I ran a little prevention program in New York for a few years, and all the programs were part of, it was called SSC at the time. There weren't these community-based kind of initiatives. But I think with home visiting and the mental health stuff we have, there's a difference, and there's a place for somebody like you who doesn't want to be in child welfare.
think we'll make this our last question. Go ahead, Del.
Hi, Dr. Jones-Harden. It's lovely to meet you. Thank you for your talk. I'm a PhD student in the School of Public Health, and I research unintentional firearm injury among young children and how to talk to parents about such an important issue. I was curious, since you mentioned programs around IPV and also just the parent-child interaction, how, if currently in the field of social work, if there's screening that's provided in home visiting models where they're asking specifically about firearm carriage, or how you would see the role of social workers to intervene in those settings if they could, or how you might approach that.
I mean, one of the things, yeah, you're asking a very good question, because there are, even with suicide, there are questions that the public health people have taught us we should ask. They've taught us questions we should ask about IPV. And I think that there's a lot of training being done for home visitors around how to make those assessments. Because as you saw, one of the things that they have to do, a million things they have to do, is attend to family violence. So there's a lot of training, but I hearken back to a paper that Ann Duggan wrote a long time ago when she was doing Healthy Families America, and I've talked to her recently, and she doesn't think it's changed. She thinks they're getting trained, but they get so unnerved by the situations that they're not really addressing it. So they know to ask the question, but they're so afraid of what they're gonna do, so afraid of their safety, that they're sort of not touching it. So I think part of what again, there's always more work to do, is to think about the physical safety of home visitors and think about, in cases of IPV, should we be doing things a little differently? Like, from my vantage point, a question is, should we be sending them by themselves to those homes at all, right? Should we be having, at the same time we have supports for mothers, should we be having supports for the perpetrators at the same time, so there's somebody who knows what to do? But I guess what I'm saying is, I think they know, but whether they do it is a different question. Yeah.
Thanks, Adele. And Brenda, thank you. I have to say, I too am a Brenda Jones-Harden groupie, like Shauna Lee and behind me. And one of the things I think I've always appreciated about your work over the many years that we've crossed our paths is just how much you prioritize research but remain a social worker at heart. I mean, that truly is who you are, and it's just so admirable. So thank you so much. We appreciate your time and your wonderful presentation.
Thank you all for
today.
hanging in there with me. This is a long time.